Assalamu alaikum. Good morning. Today we are discussing the minimal invasive technique of prostate surgery. Dr. Zubair will give you a good insight of these surgeries. Please start.
Assalamu alaikum everyone. My name is Dr. Aghamad Zubair. My moderator is Dr. Tanzeel Qadar. Today we are talking about surgical management of benign prostatic hyperplasia related LUTS, minimal invasive surgery. So a brief recall of prostate anatomy. It has three zones: transition zone, peripheral zone, and central zone. And BPH transition zone is hypertrophy. And in this slide, you can see this capsule of the prostate, true capsule, and this is endopelvic fascia, which is called false capsule. In between, there are prostatic venous plexus, which is very important in the surgical point of view. We will be discussing later on. Types of minimal invasive surgeries. There are non-laser treatments, laser treatments, and other options. Laser treatment, non-laser include monopolar TURP, bipolar TURP, URETHRAL, REZUM system, transurethral vaporization of prostate, transurethral microwave therapy, transurethral microtherapy, transurethral needle ablation, transurethral incision of prostate, and echo ablation. And laser treatment includes HOLEP lasers, YAG lasers, potassium titanal phosphates, green lasers, and TUVP. Other include intraprostatic stents, aquablation, and prostatic embolization. So, general rules are the patient should generally be trialed on medical management before proceeding to surgical interventions. Perioperative antibiotics coverage should not be neglected as serious adverse outcomes still occurs. Both patient and physician's factors should be considered when selecting the appropriate surgical management for patients. Patient factor to consider are prostate size, previous surgical intervention, history of urinary retention, inability to stop ongoing anticoagulants, and patient preferences. Surgeon factors include experience with the different treatment options and their availability in that institute. Monopolar TURP. TURP involves an endoscopic approach where the patient's urethra to surgically remove the inner portions, primarily the transition zone of the prostate that encircles the urethra. The original M-TURP required the use of non-ionic reagent glycine sorbitol to carry the current through the correct cutting loop into the tissues and through the patient to the grounding pad electrodes. And now newer technology is bipolar, use the isotonic solutions. Pre-op preparation, TURP is generally performed under general or spinal anesthesia. Patient is positioned and secured in Lloyd Davis position.
TURP usually done in the spinal anesthesia, but if there is any problem to the spinal problem is there in the patient, then we should switch to general anesthesia. But 99.9% TURP done in spinal anesthesia. Okay, yeah, carry on.
Irrigant fluid should be maintained at the body temperature and placed at the ideal height, that is 60 centimeters above the patient. This is of very much importance, as there is less chances of fluid absorption if it is in the ideal height above the patients. And fluid level may be raised during the case if visualization becomes cured by the bleeding and achieve hemostasis with the roller ball. Intraoperative, before beginning to resect, the bladder should be inspected for any bladder pathology. And the presence of middle lobe should lead the surgeon to start the resection there. But when resecting the lateral lobes, some surgeons prefer to resect the floor of the prostate urethra initially between the 5 and 7 o'clock position, and others use the modification of the Nesbitt procedure in circumference approach. In Nesbitt, usually surgeon starts the treatment at 12 o'clock position. There are certain methods through which TURP can be performed by Nesbitt procedure, Meyer procedure, and Barnes method, Alcock and Flox method, and Blandy's method. The important thing to note here is the cutting current should be at 120 watt, and the coagulation current must be kept at 80 watts. Approach to transurethral resection of prostate, starting with the prostatic floor. As you can see in the figure A, view from the resectoscope with an electrosurgical loop resecting the prostate floor, and the B resecting the lateral lobes. Sagittal view of the resection of the prostatic floor, and D showing the continuing resection down the capsule, and E complete resection of this section of the prostate, leaving some residual apical tissues to avoid injury to external sphincters. Adequate fluid should be kept in the bladder to avoid inadvertent bladder perforation with the loop extended.
एक मिनट जुबैर. Jamal, can you tell me the limits of TURP when you are doing the TURP? What are the limits of yours? यानी आपकी बाउंड्रीज क्या होंगी, कहां तक आप रिसेक्ट करेंगे? और कमल,
proximal to the verum montana. We should not extend beyond the verum montana to damage the
why?
To damage the sphincter and patient will
External sphincter. If we go beyond to the verum montanum, then we can damage the external sphincter, and then there may be a problem of incontinence. Okay, thank you. Continue.
Exposing venous sinuses will predispose to bleeding and fluid extravasation absorption and compromise the resection and patient outcome. The prostate apex is best resected at the end of procedure in a bloodless field where resection can be done precisely to avoid injury to external sphincter. And one must complete the one medial lobe first, then the one side of the lateral lobe, and then moving to the other side. You should not be doing half cutting with the one lateral lobe and other, so that to avoid the absorption of the fluid, which may lead to TUR syndrome. The arterial bleeding is characterized by its bright red and persistence even with irrigation running over the area of hemorrhage. This type of bleeding will persist during filling and drainage of the bladder, and venous bleed will often disappear with the full bladder as it applies pressure to the prostatic fossa. The amount of fluid placed in the balloon should be tailored to the volume of resected tissue to avoid the catheter balloon falling into the excavated prostatic fossa.
एक मिनट. अच्छा अच्छा ठीक है.
सही कह रहे हैं. बिल्कुल बिल्कुल ओके थी उसका. और यहाँ से मैंने जो ना नेट के सिग्नल भी चेक किए, बिल्कुल ओके हैं बिल्कुल यहाँ से.
Monopolar TURP. Post-operative care, when ordering post-op fluid, one should remember that even an uncomplicated resection has fluid absorption between 800 ml and 1000 ml. In the absence of significant capsular perforation or persistent bleeding, the catheter can be removed in 24 to 48 hours. Patients should avoid activities that place excessive or uneven pressures on the perineum for 4 to 6 weeks. And post-procedure, one should examine the abdomen for any distension post-op procedure. The outcomes review by Agency of Healthcare Policy and Research indicates an overall symptomatic improvements of 88% for TURP. These data review indicated that surgical procedures in general produce about 80% improvement in symptoms score compared with 30% to 40% range for placebo and non-surgical therapies. Considerable and durable changes in IPSS, quality of life, and QMAX, and many other widening lifestyle measures have been observed at TURP. Coming to the potential complications of TURP. One encounter peri-op and immediate post-op retention in 6.5% of the patients, UTI, bleeding, clot retention, injury to ureteric orifices, rectal injury, TUR syndrome, capsular perforation, and storage symptoms, likely dysuria and urgency frequency. And post-op delayed bleeding current 4 to 6 weeks by the slugging of the epilation of the prostatic fossa, and bladder neck contracture in 2% of the patients. Urethral structure is seen in around 4% of the population, meatal stenosis, urinary incontinence, erectile dysfunction, and retrograde ejaculation, which is significant, about 60%. And that's why more newer technologies are being introduced to decrease this percentage. Extravasation and perforation of prostatic capsule. Extravasation related to prostatic resection is almost always extraperitoneal, occur in 2% of the population's patients. Restlessness, nausea, vomiting, abdominal pain, and distension. And management include control any bleeding and stop the procedure immediately. Urethral catheter drainage, which is enough in 90% of the patients, or suprapubic tube if extensive extravasation and or concern about infected perivesical tissues. The TUR syndrome. The prostate venous system has a pressure of approximately 10 millimeter of mercury, and fluid as a pressure exceeding this will lead to fluid absorption when these vessels are exposed during resecting, leading to TUR syndrome. The pathophysiology behind is likely dilutional hyponatremia or ammonium toxicity might be the possible cause, as glycine metabolized to glycolic acid, ammonium, and act on inhibitory neurotransmitters, thereby causing the seizures and other symptoms. Occur in 2% of population, usually not symptomatic until serum sodium is less than 125 millicurie. It includes nausea, vomiting, confusion, hypertension, visual disturbances, bradycardia, tachycardia, pulmonary edema, and seizures. The risk factors include glands greater than 45 grams and long resection time, approximately greater than 90 minutes, deep resection or capsular perforation, open veins, lots of irrigant use, elevated height of irrigant during TURP, congestive heart failure, and liver failure. How to manage the TUR syndrome? Depend on the sodium and patient condition, can range from confused to comatose. Stop TURP as soon as hemostasis achieved, 3-way forage with continuous bladder irrigation, normal saline, may need intubation if loss of consciousness or evidence of elevated intracranial pressures, baseline investigation and fluid management of fluid overload with furosemide, 40 milligram IV or menthol 0.5 grams per kg. Consider hyperventilation if signs of elevated intracranial pressures, manage hyponatremia, don't overcorrect the sodium, and if there are seizures, we can give them lorazepam or phenytoin. So one complication.
Sir, I have a question. We have a very large clinic of prostate in our hospital. So do we have any patient post-TURP patients suggesting that there is a erectile dysfunction, and what percentage of erectile dysfunction in the patient population?
Now, erectile dysfunction sometimes is there, but most of the time it is of a transient nature, which means that it stays only for a couple of weeks. And during those post-operative times, the patient itself is in a phase of convalescence. So we do not have a specific kind of population of patients who tell you that they are suffering from erectile dysfunction. So this is something which is where privacy is needed, where something called a special place for these kind of patients, but usually these patients do not come up. So I'm not referring that they are not there. They might be there, but since they are not coming up, so I cannot give you the exact figure or the percentage. But to my understanding of the past many years, I haven't seen many patients, maybe a couple of patients, not more than that.
So management of intraop priapism. Phenylephrine or ephedrine injection through copper, cavernosa, and deep anesthetic and ketamine use or dorsal nerve block to manage the intraop priapism. Coming to bipolar TURP, bipolar technology allows for quicker resection as bleeding vessels are less likely to be encountered as the simultaneous cutting and sealing of vessels decrease time spent controlling hemorrhagic areas. Normal saline isosmolar is used as irrigant, thereby have low incidence of TUR syndrome. The results for the bipolar resection system are encouraging, and this technology will likely replace monopolar TURP as the gold standard for treatment of BPH in coming years. The current setting is in bipolar is 200 watts for cutting, and for coagulation is set at 120 watts. The advantages, of course, there is short catheterization time on 3 days as compared to the monopolar TURP, low acute urinary retentions, urethral strictures rates are considerably low, and bladder neck contracture in monopolar TURP was 2%, and in bladder neck contracture in bipolar TURP is 1.2%, and urinary incontinence is around 0.7% of the patients.
Now, just a word about again what you actually posed that question, and it was about erectile dysfunction. You see, whenever you have a clinic, a facility available for any kind of complaint, then these patients do team up, they group up, and they come to you. Now, since we do not have a facility, a special clinic, or a place where we deal with erectile dysfunction. We do not have a specific kind of algorithm for these kind of patients. And this is a kind of a taboo that the patient should think about it. So many of the patients who have got this problem, either they come in the filter clinic at the very end of the clinic, not in the middle of the clinic, and they do not come to each and every doctor. So they always come to a doctor whom they think that they have got the experience, or maybe they have got the confidence in them. So it is something which is, again, according to the culture and the society, many patients do not come up. So if you want to see the actual magnitude vis-a-vis TURP or vis-a-vis your stricture disease or any kind of a trauma related to the occurrence of erectile dysfunction, then you must create a separate clinic, a special clinic, and where people are there who can deal with these kind of problems through different techniques, maybe starting from psychoanalysis to drug therapy to something which is yeah. So once it is done, then you will see maybe a lot of patients, maybe a true figure of the complication, but still I cannot give you, or nobody can give you the true figure of these kind of problems.
Moving forward,
Arslan, in which patient you want to do the bipolar TURP? किस patient में आप bipolar TURP करना चाहेंगे? कौन? If there is a patient had a PPM, permanent pacemaker, then we should do the bipolar TURP in that patient. And if there is a cardiac compromise, then we have to do the bipolar in that patient.
Moving forward, there are certain other recent advancements in the management of BPH with considerable outcomes as compared to monopolar TURP. The first one is prostatic urethral lift, commonly called as URETHRAL. It works by altering prostatic anatomy without ablating the tissues, prostatic tissues. These permanent transprostatic implants take the form of sutures that are delivered by the handheld device through a cystoscope. The URETHRAL is used to treat the lateral lobes of the prostate and is thus not appropriate for patients with the median lobe. The particular advantage of this technology includes low rates of local symptoms along with the minimization of impact on sexual factors like erectile dysfunction and ejaculatory problems. How this implant is placed, we'll see in the preceding slides in a short video clip. The implants are placed anterolaterally in the prostate, preserving the bladder neck, maintains the ejaculatory functions, indicates for prostate less than 80 grams. URETHRAL is contraindicated in men with median lobe. Comparative studies showed retreatment rates for 13.6 for URETHRAL and 5.7 for TURP. Another study done by Wood et al. Showed ejaculatory bother improves by 40% at 1 year, and intensity of ejaculation and amount of ejaculatory improved by 23 and 22% respectively. The small video clip, how the procedure is performed.
You can see here in this artist rendering, a cystoscope is inserted into the urethra and into the prostate. The prostate is then compressed and the urethral lift is then deployed. The implant is deployed to the outside of the prostate initially. It's then attached to the suture anchor. And there's a urethral clip applied on the other side. What this does is compresses the tissue, both the inside and outside, to open the urethral channel. The same technique is then applied on the other side. Now, in this artist rendering, this is quite slow. In real life, this is a split-second deployment. Here you can see now it's on both sides. Now the urethral channel is open. Oftentimes, a total of 4 clips are applied, sometimes even more. You can see the before photo here and the after photo here. So quite a big difference between the two. And when you're looking on the inside, very big. Here's the actual implant. It's quite small. There's a urethral end piece and a capsular end piece. You can see here in this artist rendering.
REZUM therapy. There is another modality to treat the BPH. It is a convective radiofrequency water vapor thermal therapy. What is convective radiofrequency? It is use media to disperse the energy as compared to the other therapies we will be discussing later on. It utilizes convective rather than conductive energy to ablate prostatic tissues. REZUM utilizes radiofrequency power to generate thermal therapy in the form of water vapors, which is injected transurethral into the transition zone of the prostate. The water vapor is injected at 103 degrees centigrade for 9 seconds at a pressure slightly above interstitial pressure, facilitating the dispersion of water vapors through the cellular interstices via the convective energy. What are the advantages?
Basically, it is a steam energy which will necrose the part of the prostate, and then there is a reduction in the size of the prostate. At 6 months, it is 30% reduction of the size of the prostate, and which leads to the improvement of the symptom. And there is a IPSS score improvement is 47%. The quality of life is 43% improvement, and the Qmax is 50% improvement. So it is a very good therapy, and it needs only 10 minutes, 10 to 15 minutes, and we can do in local anesthesia as well as in sedation.
It can be done in the clinical setup, outpatient settings performed by the oral sedation, conscious sedation, or regional block, both a favorable safety profile and low retreatment rates. No change were noted on sexual function ejaculatory, both improves by 31% at 12 and 24 months of follow-ups.
So best thing is that there is no change in erectile function of the patient. So this therapy is in, and most of the centers in Europe and America, they are doing the REZUM therapy.
So another short video clip, how the procedure is performed.
The following is an example of a REZUM procedure in a 51-gram prostate. After priming, the delivery device is placed into the urethra and advanced to the bladder. Once the bladder is entered, it is recommended to measure from the bladder neck to the viru to determine the length of the prostatic urethra. One field of view represents 0.5 centimeters, and each treatment should begin 1 centimeter from the bladder neck, moving toward the viru in 1 centimeter increments. Once measurement of the prostatic urethra is complete, return to the bladder neck and begin treatment on one side of the prostate. It is Dr. Cantrill's practice to start on the left side of the prostate, but either side is acceptable. Once beginning treatment, continue ipsilaterally to the viru, targeting the bulk of the adenoma. It is recommended to allow the needle to remain deployed for 1 to 2 seconds after completion of the 9-second treatment to ensure all phase change of water vapor is completed. If a vapor leak is detected, noted by rapid release of bubbles, moving the delivery device gently in the direction of the leak will help to seal the leak and continue with the therapy. With large vapor leaks, greater than 3 seconds of the therapy, it is recommended to retreat the area with an additional treatment. Taller prostatic urethra may require stacked therapy to create a continuous channel, or a Z-like pattern may be used to follow the natural course of the urethra with an elevated central zone. When intraprostatic protrusion is noted of the lateral lobe.
Okay. Coming to transurethral vaporization of prostate, this technique used the same set of equipment as TURP at that time, with the exchange of a resecting loop for an element with a larger surface area. As the leading edge of electrode makes first contact with the virgin tissues, a high volume of energy is delivered and leads to tissue vaporization. The cutting current is used for vaporization, and with the fulguration current leading to tissue coagulation. Common monopole power settings are 200 watts to 240 watts for cutting current and 60 watts for coagulation. The bipolar technology used setting of 280 watts and 140 watts. Study shows the comparable improvements in symptom scores and Qmax. Some complications similar as a TURP would be irritative LUTS, UTI, 1 year reoperation rate, and urethral strictures. Better than TURP in the fields of earlier removal of catheter, less hematuria and transfusion rate, lower retrograde ejaculation rates, and shorter hospital stays. And worse than TURP, there is no sample for histopathology. higher post-op retention rates, higher rates of erectile dysfunctions, and higher rates of incontinence. Just another video to give you an insight. Instrument is just like TURP, conventional electrode, and in this setting, the this is done in saline solution. Vaporization process first is create a vaporization, thereby making an energy source, which then leads to cutting of the prostatic tissues. The real-time settings, it looks like this. As you can see, there is no tissues for histopathology in this procedure, just a drawback. And moving forward, transurethral microwave therapy. The objective of TUMT is to locally thermoablate the prostatic tissues while maintaining normal temperature in the surrounding non-targeted tissues. This concept uses a specialized urethral catheter with an antenna that generates a radially emitted electromagnetic waves. This is the specialized catheter. Hemorrhagic necrosis of tissues after 60 minutes of exposure to a minimum of 45 degrees Celsius. When heat is applied to a specific portion of the prostate to sufficient temperature and duration, an area of necrosis is created. This area of necrosis eventually contracts to form a scar and reduce overall prostate volume. And how successful is the TUMT? There's moderate improvements in symptoms, Qmax improvement by 3 cc per second, prolonged catheterization more common after TUMT. Retreatments are more common as compared to TURP. Lower rates of retrograde ejaculation and urethral strictures are noted, and presence of median lobe is an exclusion criteria. Transurethral needle ablation of the prostate. Low level of radiofrequency waves used to produce localized necrotic lesions can be delivered under local anesthesia. Doesn't work well on large blood vessels, and hot central core of 90 to 100 centigrade, very quick decline in temperature is distant increase from needle. Indications are lateral lobe enlargement, 60-gram prostate, not more than that, and poor surgical risk patients. The other outcomes, it is almost as good as TURP with respect to improvements in symptoms and Qmax. 13 symptoms and unit improvements, 6 cc Qmax improvement, and retreatment are more common after needle ablation as compared to the TURP. 15% need retreatment within 2 years. Complication rate is lower. What are the complications? Urinary retention in 40% during first 24 hours, irritative LUTS, UTI, urethral strictures, hematuria, no adverse effect on sexual dysfunction and retrograde ejaculation are noted, and the study conducted in 2004 by Hill et al. No urinary incontinence after transurethral needle ablation has been noted. Transurethral incision of prostate. It is an operative approach to disrupt the prostatic capsule to alleviate voiding symptoms. Incision using Collins knife made at 5 and 7 o'clock through the bladder neck to just proximal to verumontanum, and indicated in a prostate with less than 30 grams and a high bladder neck, comparatively in younger men. How successful is a transurethral incision of prostate? There is some degree of improvement in Qmax and PSS system scoring, but not as good as TURP. The positive thing is it has shorter OR time and shorter duration of catheterization and lower rates of retrograde ejaculation and erectile dysfunction. Coming to the laser treatment of benign prostatic hyperplasia. The laser prostate treatment rely on the prostate interacting with the light energy and converting it into local thermal energy. Coagulation achieved at temperature of 90 degrees centigrade when vaporization at 100, greater than 100 centigrade. Following procedure use the laser on the prostate, HOLEP, holmium laser enucleation, thulium laser enucleation, transurethral ultrasound guided laser induced prostatectomy, visualized laser ablation of the prostate, transurethral evaporization of prostate. Laser are classified by their inherent wavelength, maximum output power, and risk for damaging the eye or skin. It is very important to note the damage to the eye. It can lead to serious outcomes at the certain wavelengths. When laser is used, one should be putting in things to minimize the risk of eye damage, like putting the eyewears and cover the operating rooms, windows and everything. We will be focusing more on holmium laser enucleation of prostate. In this wavelength is short, strongly absorbed by water and water-rich tissues, and has an absorption length of 0.4 millimeter with an excellent hemostatic properties. It is endoscopic equivalent of open prostatectomy. So means it can be done in the process of greater than 100 grams or 150 grams. The laser fibers is delivered through a laser catheter to help stabilize the laser fiber, while at the end of catheter there is locking mechanism to keep the fiber at fixed length during the procedure. Performed using high power holmium laser micron laser fibers, and 80 watt or 100 watt generator is used. The power setting are generally 2.0 joules to 50 hertz, giving the surgeon a total of 100 watts. In this, the plane is enveloped between the adenoma and capsule to dissect the lobes of prostate. The enucleated adenoma is extracted with the help of morcellator. So what is morcellator? It is a device which helps extract the enucleated as a whole tissue to cut it into pieces inside the bladder and get the sample out of the prostate. Main drawbacks are expense, difficulty learning curve, risk of bladder damage during morcellation process. Hybrid holmium laser enucleation techniques have been described, and by Helfeld improves the learning curve and has decreased complication rates compared with traditional HOLEP. What are the outcomes? In a study of patients with a mean volume of 6 cm of urine drain at initial catheter placement, only 1.75% of patients were unable to void after surgery. Another study conducted on 1065 patients showing significant improvements in Qmax around 22.7 ml per second, and IPSS improvement to 5.3. Retrograde ejaculation is a common finding after HOLEP, with 2 randomized trials finding incidence rates of 75 and 78%. The incidence of bladder neck contracture is 0 to 3.2%. Urethral strictures is a common finding with the incidence as high as 7%. So another short video clip, last one. Again, any procedure, before doing start the procedure, you should be inspecting the bladder, the aortic orifices, as shown in this video. And you can this is a laser fiber. First, the median lobe is given in the advantage is this: in this laser treatment, a whole of the lobe is enucleated rather than in the form of chips in the TURP. So, okay. median lobe has been enucleated completely and pushed into the bladder. It will be taken out by help of morcellator later on. Types of laser used to treat prostate or Holmian Yeg lasers absorb water and leads to vaporization. Energy emitted in a series of rapid pulse over a few milliseconds has an absorption length of 0.4 millimeters with excellent hemostatic properties, produce more of a cutting effect and less of a hemostatic effect. The other lasers are anti-Yeg lasers, poor absorption by water and so leads to coagulation, continuous energy waves as compared to the HOLEP, which shows non-continuous energy waves, penetrates tissue relatively deeply, dangerous for retina. And there is greenfield potassium titanal phosphate laser. It use continuous energy waves, penetrate only half as deeply as anti-Yeg lasers, and use high energy than anti-Yeg lasers. What are the advantages? Coming to advantage, there is no bleeding or very minimal bleeding, can treat anticoagulant patients, not UR syndromes, can be used for larger glands as it is compared to open prostatectomy. And disadvantages are long catheter time, coagulation necrosis, and prolonged irritative symptoms. And of course, it is very expensive. These are the expected complication rates comparative in different modalities, like in uterine stricture is 3.4 to 4.1%, and monopolar TURP, and in microwave therapy and tuna, it is relatively less. And similarly, the capsular perforation is there in TURP, but less chances as compared to other studies. And QR syndrome is common in M-TURP as compared to others, almost negligible. Moving forward, another advancement is intraprostatic stents. The stents provide a rigid framework once in a place in the prostatic fossa, push outward to open the prostatic lumen. A stent can be classified into many categories, including temporary or permanent, epithelializing, and non-epithelializing. In the epithelializing version, the stent is incorporated into the urethra as the urothelium grows into the stent, which should prevent interstitial migration. Permanent stents have largely been relegated to use in older men with medical comorbidities that severely restrict their treatment options because of the inability to tolerate any level of anesthesia. Fairly high complication rate, including epithelial hyperplasia, migration of stent, irritative LUTS, painful ejaculation, and prostration. Aquablation. This truss-guided technology utilizes a non-thermal high-velocity saline water jet stream to ablate the prostatic tissues. A real-time truss probe defines the treatment area, and a robotically guided transurethral system then quickly hydrodissect target areas. The Aquabeam system, the 24-hour Aquabeam system is manufactured by PROSTATE Biorobotics and includes a console or pump and a robotically controlled handpiece and a truss probe. The 24-FR handpiece with integrated cystoscopy is inserted transurethral into the position and then locked into place via the bed rail mounting calculating arms. The angle of resection is first selected, followed by visualization of the prostate in the sagittal view to confirm the treatment zone of the shape of the adenoma. The treatment zone is adjusted to exclude the bladder neck and external sphincter and focus on the adenoma. And with this new application of robotics, the transition zone can be precisely defined for treatment, which should ideally minimize under treatment of the prostatic adenoma. The procedure does require general anesthesia, making it difficult to characterize as a minimal invasive surgery, but may demonstrate improvement over conventional BPH treatment like TURP. Last but not least, prostatic embolization. The catheter has been advanced into the prostatic arteries via femoral arteries, and embolizing agent, alcohol or microspheres, is then infused through the catheter until stasis is seen in the prostatic vessels. Bilateral procedure ensure better results as compared to the unilateral embolization of prostatic arteries. As seen commonly in embolization of blood-rich organs, a post-embolization syndrome of pain and fever is customary. A technical challenging and high variable pelvic anatomy may limit the widespread acceptance of this technology, with only expert interventionists performing the procedure. Completed studies have largely been non-rigorously performed, and application of a generated data makes it difficult to predict the role of prostatic embolization in the treatment of LUTS and BPH. This concludes my presentation. Thank you.